Let me say one more
Yeah,
thing.
sure.
So in regard to diagnosis, which is I think what we're speaking about, one important thing for our internal medicine colleagues is the exclusion of other diagnoses that are important. So what are the confusing or confounding diagnoses around osteoarthritis? So we need to rule out rheumatoid arthritis and the inflammatory arthritides, and that can be done with lab tests, right?
Which lab tests?
A simple SED rate will help diagnose
They
these.
still do those?
They still do those.
Yes.
Rheumatoid factor. There are a number of other markers for
I
inflammatory.
want to get back to,
arthritis.
they're still doing SED rates?
They are, and
Yes.
we'll talk about it in a second. Gout, I think, is another thing that needs to be ruled out if they have recurrent effusions. And sepsis needs to be ruled out if there are any.
So an infected joint is what you
Yeah,
mean?
I think that's an emergency. So that can't wait 6 weeks, right? So
Okay.
So I think, Peter, it's important to put this in context. It's quite unusual for multi-joint rheumatoid arthritis to just present as one knee. It can do that, but usually these are women in their 30s or late 20s or occasionally older with multi-joint, and that their hands are bothering them, their feet and their knees. I think for the internist, I think they should be aware of if there's pain at rest or pain at night early on, it could be something else. Usually osteoarthritis pain is with activities or with weight bearing, or they have difficulty doing an activity. I always worry about hidden neoplasms or something. If patients have terrible pain or numbness in the limb, it shouldn't be confused.
And
with
osteoarthritis will get better with rest, right?
Right.
Yeah, I was going to start with that. I was always taught if they wake up with swelling and pain, it's probably more likely rheumatoid. If it gets worse with activity during the day, it's more likely osteo.
But both will be stiff in the morning. I mean, and the other great mimicker is Lyme disease, right? We need to be aware of that in the Northeast.
I wish I had a nickel for every time Lyme disease popped into a differential. It's common, it's everywhere, and it's arthritic. I mean, the original phrase that we used to use was Lyme arthritis. Correct. Right? And it was originally misdiagnosed as rheumatoid. So Lyme's in the differential everywhere, and you can, and even the serologic tests for Lyme are inconsistent, I guess is the best phrase for it.
I think the other thing that I would stress as well along these lines is that doing the basics, the history and the physical examination, will help us enormously, particularly when you find that patient who complains about knee pain but has a completely normal exam and their x-rays look normal and they're not swollen. And you as an internist can be of tremendous help to us. I must have 5 or 7 patients a year that come in who are on statins, and the statins are causing musculoskeletal pain. Those kinds of things that we perhaps may not be as familiar with are tremendously helpful, so that once they do come to the specialist, we can sort of focus on the knee and understand really what's going on that's causing that knee pain.
Now, I don't want to leave this discussion of some of the criteria that we use for the diagnosis without coming back to that bugbear we were talking about, which is radiology. Sure. So, plain films, weight bearing, avoid the MRI. What do you look for on a plain film? You mentioned it. Why don't we just run it down again?
So you essentially look for the black space on a plain radiograph, which represents the cartilage. So it should roughly be 4 to 5 millimeters on each side. And if there's a decrease in that, that's the earliest sign of osteoarthritis, followed by spurring or osteophyte formation at the edges of the joint. One of the things that we didn't bring up that also the internist should think about is if they can get a chance to see the patient walk, because oftentimes hip arthritis will present as knee pain. It's not that common, but I think we've all would agree we've seen patients who've had knee arthroscopic surgery or even partial knee replacements where the actual problem was the hip. And there's a type of hip arthritis that can present as knee pain.
Is that because they're favoring what used to be the good side because the other side
I think
hurts?
it's referred pain for the most part, yes. So
Hip pain will start in the groin and will refer down the anterior part of the thigh to the top of the knee.
Really?
And that would be hip, posterior pain we generally.
So it's not just an antalgic
Say is-
gait, it is really referred pain.
Correct.
That's fast. I did not know that. You learn something
See,
new
you
every
learn
day.
something,
here, you see?
Peter.
That's great.